Alright, this is Chapter 21, Endocrine and Hematologic Emergencies. Your National EMS Standard Competencies for medicine applies to the fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely ill patient. Endocrine disorders. This is awareness that diabetic emergencies called altered mental status, AEMT patho assessment and management of acute diabetic emergencies. We're going to talk about hematology, the AEMT patho assessment and management of sickle cell crisis and clotting disorders. The human endocrine system directly or indirectly influences every cell, organ, and body function. Endocrine disorders can have many signs and symptoms. They require a thorough assessment and immediate treatment. Hematologic emergencies have the following characteristics. They are rare in most EMS systems, difficult to assess and treat in the pre-hospital setting, and an advanced EMT can offer support and may save a patient's life. AEMT review of the endocrine system. The endocrine system comprises a network of glands that produce and secrete chemical messengers called hormones. The major components of the endocrine system include the hypothalamus, pineal gland, pituitary gland, thyroid gland, thymus gland, parathyroid gland, adrenal glands, the pancreas, and gonads. Hormones are chemical substances produced by glands that have special regulatory effects on other organs and tissues. Endocrine glands secrete or release chemicals such as hormones inside the body. The main function of the endocrine system and its hormone messengers is to maintain homeostasis and promote permanent structural changes. The pituitary gland is located at the base of the brain. The pituitary gland is divided into anterior and posterior regions. 6 of the hormones secreted by the pituitary gland stimulate other endocrine glands and are referred to as tropic hormones. These are the adrenocorticotropic hormones, the ACTH, follicle stimulating hormone, growth hormone, luteinizing hormone, prolactin, and thyroid stimulating hormone. ACTH targets the adrenal cortex and causes it to secrete cortisol. The thyroid gland. Thyroid hormones are secreted in response to stimulation of the thyroid gland by the anterior pituitary gland. It secretes thyroxine when the body's metabolic rate decreases. It stimulates energy production in cells. The thyroid gland also secretes calcitonin, which helps maintain normal calcium levels in the blood. Calcitonin travels to the bones where it stimulates the bone-building cells to absorb the excess calcium. The pancreas is considered both an endocrine gland and an exocrine gland. And that sounds like a great test question. The endocrine components excretes hormones from cell groups called the islets of Langerhans. These cell groups within the pancreas act like an organ within an organ, secreting the polypeptide hormones, insulin, and somatostatin, maybe. The role of glucose in, gotta change my slide there. The role of glucose and insulin. Glucose is one of the basic sugars in the body and along with oxygen is the primary fuel for cellular metabolism. It is the major source of energy for the body. Without glucose or with an extremely low glucose level, brain cells rapidly suffer permanent damage. With the exception of the brain, insulin is needed to allow glucose to enter individual body cells to fuel their functioning. Regulation of glucose levels in the body is a complex and dynamic process. Insulin is responsible for the removal of glucose from the blood for storage as glycogen, fats, and protein. When blood glucose levels are elevated, the following process occurs. The islets of Langerhans secrete insulin, which is carried by the bloodstream to the cells. Insulin increases cell membrane permeability and mediates the transport of glucose across the cell membrane into the cells. The cells use glucose to produce energy through processes that include glycolysis. Insulin also stimulates the liver to store excess glucose, and the skeletal muscles store glycogen for later use by the body. When the glucose level decreases, such as between meals, the following process occurs. The alpha cells of the islets of Langerhans release the hormone glucagon. When glucagon enters the bloodstream, it raises the blood glucose level and brings the body's energy back to normal by stimulating the liver to convert stored glycogen back into glucose through the process called glycogenolysis. The glucose is secreted into the bloodstream where cells can use it for energy. If stored glycogen levels are depleted, the cells begin to metabolize fats, proteins, and other non-carbonate sources, thus producing new glucose, a process called gluconeogenesis. Pathophysiology of the endocrine system. The endocrine disorders can be caused by either hypersecretion or insufficient secretion of a gland. Hypersecretion presents as overactivity of the target organ regulated by the gland. Insufficient secretion results in underactivity of the organ controlled by the gland. Hyperthyroidism and hypothyroidism are two serious illnesses of the endocrine system. Most of the endocrine emergencies you will encounter will be related to diabetic emergencies secondary to abnormal insulin secretion. Hypothyroidism and hyperthyroidism. Hyperthyroidism increases metabolism while hypothyroidism decreases metabolism. Table 21.1 in the text summarizes major effects of hypo and hyperthyroidism. Diabetes mellitus. Diabetes is a metabolic disorder now thought to be associated with a group of complex diseases with many causes. Diabetes mellitus, gestational diabetes, hypoglycemia, hyperglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome. The end result of diabetes is hyperglycemia. Medically, the term diabetes refers to a metabolic disorder in which the body's ability to metabolize simple carbohydrates or glucose is impaired. Diabetes is characterized by the following symptoms: polyphagia, polydipsia, and polyuria. What are those? Somebody.
Increased appetite, excessive thirst, and polyuria is a large quantity of urine.
Very good. Right, diabetes mellitus is characterized by the body's inability to sufficiently metabolize glucose. Mellitus is the reference to the presence of glucose in the urine. Glucose builds up in the blood, overflows into the urine, and flows out of the body. Diabetes mellitus is responsible for myriad life-altering complications, some of which are listed here. The kidneys, you have high levels of glucose in the blood because the kidneys have to work harder than normal and can result in decreased kidney function over time. For the heart, when diabetes is poorly controlled, the process of lipolysis raises the level of fat in the blood, increasing the risk of atherosclerosis and coronary artery disease. The microscopic deterioration of the vessel walls, called microangiopathy, results in swelling of basement membrane cells. Cerebrovascular disease, stroke, and hypertension. The eyes, high glucose levels in the blood damage the vessels of the eyes, causing swelling, wall weakness, and obstruction. Neuropathy, and that's nerve damage that results in the loss of sensation and function in the area innervated by the affected nerves. Neuropathy associated with diabetes often affects peripheral nerves, causing diminished sensation and function in the extremities. I would like to add also neuropathy in the process of those extremities becoming having the weakened nerves in there. That's a very painful process, y'all. As those nerves begin to die, there's a lot of pain associated with that. So before it comes to a point where that extremity and the sensation is numbing, it's is painful, and that can take a very long time for that process to complete. Because of the widespread effects of diabetes on all systems of the body, any pre-existing condition will be more difficult to manage. Any kind of distress can have a negative effect on the patient and result in a 911 call. Both chronic and acute complications are associated with diabetes mellitus. Left untreated, diabetes results in organ system dysfunction and wasting of body tissues and even death. Two forms of diabetes exist. Type 1 was formerly known as juvenile onset diabetes, and type 2, formerly known as adult onset diabetes. Prediabetes is now recognized as a warning sign that may precede the development of type 2 diabetes. Type 1 diabetes mellitus. Historically, this has been referred to as insulin-dependent diabetes mellitus or juvenile onset diabetes because it generally affects children. It has a hereditary predisposition. Environmental factors may play a role. The body develops autoantibodies that incorrectly identify the body's own tissues. The rate of beta cell destruction is variable. Latent autoimmune diabetes in adults is a variant of type 1 diabetes that occurs in adults older than 30 years of age. Patients with latent autoimmune diabetes in adults will ultimately require insulin therapy. In addition to daily insulin injections, strict dietary control must be observed. Increased activity and alcohol consumption can result in low blood glucose levels. It always requires the use of insulin that is administered by injection or an insulin pump. Insulin pumps provide improved control of blood glucose levels and better quality of life for many patients. Type 2 diabetes is the most common form of diabetes. Blood glucose levels are elevated because the body becomes resistant to the insulin produced. Type 2 diabetes typically develops when a person is middle-aged, although the disease is becoming more common in younger people. When glucagon levels remain high, excess amounts of glucose are produced, resulting in high blood glucose levels. Symptoms of untreated type 2 diabetes may include fatigue, nausea, frequent urination, thirst, unexplained weight loss, blurred vision, frequent infections and slow healing of wounds, being cranky, confused, or shaky, unresponsiveness, and seizures. Weight loss is an important factor in helping to control type 2 diabetes. Metformin is the medication most commonly prescribed for the management of type 2 diabetes and causes a decrease in glucose production. Prediabetes is a condition identified in people who have certain risk factors associated with type 2 diabetes. It exists when blood glucose levels or hemoglobin A1C levels are above normal levels, yet not high enough to be diagnosed as diabetes. The goal for a diabetic patient is an A1C level of 7% or less. Risk factors include the following characteristics: older than 45 years, being overweight, a family history of diabetes, being of African American, Hispanic, Latino, American Indian, Pacific Islander, and some Asian American racial or ethnic backgrounds. Gestational diabetes, or having given birth to a baby who weighed more than 9 pounds, which is 4 kilograms. being physically active fewer than 3 times per week. Losing 5% to 7% of the patient's body weight and getting at least 150 minutes of physical activity per week can prevent or delay the onset of type 2 diabetes. Gestational diabetes. This is a form of glucose intolerance that can occur during pregnancy. For most women, gestational diabetes will resolve before delivery. Blood glucose crosses the placental barrier. When a pregnant woman is hyperglycemic, high levels of glucose enter the fetus, causing increased production of insulin by the fetus. It is thought that two hormones produced by the placenta, progesterone and estrogen, result in insulin resistance. It does not produce birth defects. Management includes diet modification, exercise, and blood glucose testing. Hypoglycemia. Hypoglycemia in a person with type 1 diabetes is often the result of having taken too much insulin, too little food, or both. Hypoglycemic crisis, also known as insulin shock, is the result of hypoglycemia. Counterregulation is the body's natural defensive ability to maintain blood glucose at an appropriate level. The body's first line of defense against low blood glucose is to reduce insulin production by the pancreas and to increase glucagon production by the alpha cells. The body's second line of defense is the secretion of catecholamines by the adrenal gland. Stimulation of the autonomic nervous system generates signals that allow production of counter-regulatory hormones to increase. The liver uses these products to make new glucose for the body in a process called gluconeogenesis. In patients with type 1 diabetes, the islets of Langerhans do not make insulin. In patients with type 2 diabetes, the pancreas can generate insulin, so these patients can suppress insulin production from within their own bodies. The lack of glucagon response makes the body more dependent on epinephrine to overcome the effects of hypoglycemia. A patient with hypoglycemia will experience trembling, a rapid heart rate, rapid shallow respirations, sweating, and a feeling of hunger. Some of the most common signs and symptoms of hypoglycemia include a blood glucose level less than 70, hunger, agitation, irritability, or combative behavior that cannot be explained, altered mentation or confusion, nausea, weakness, dizziness, or fainting, tachycardia, which causes poor cardiac output, and cool and clammy skin. Hypoglycemia is a common problem experienced by patients with either type 1 or type 2 diabetes. A hypoglycemic patient appears intoxicated because of slurred speech and lack of coordination and may be paranoid, hostile, and aggressive. Hypoglycemia can be treated easily. Severe hypoglycemia resulting in loss of consciousness or altered mental status is a more common reason to call 911. As an EMS professional, you will need to promptly provide treatment to these patients. Do not discount the possibility of hypoglycemia in a comatose patient just because the patient is not known to have diabetes. Do not let a known diagnosis of diabetes prevent you from considering other causes of a coma.
Yes.
Okay. All right, hyperglycemia and diabetic ketoacidosis. Hyperglycemia occurs when blood glucose levels remain elevated and mechanisms that normally correct this have failed. It can be caused by excessive food intake, insufficient insulin dosages, infection or illness, injury, surgery, and emotional stress. Hyperglycemic crisis, also known as diabetic coma, is a state of unresponsiveness resulting from several problems. Onset may be rapid within minutes or gradual and take hours to days, depending on the cause. Repeated episodes of hyperglycemia will cause several physiologic changes that have detrimental long-term effects. When serum glucose levels rise above tolerable levels, physiologic changes occur representing pathologic conditions called diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic syndrome, or HHS. Common causes of DKA include infection, injury, alcohol use, emotional distress, and illness such as stroke or myocardial infarction. In patients with DKA, hyperglycemia continues. The loss of water in large amounts causes the classic symptoms of uncontrollable diabetes. This is the three P's: polyuria, polydipsia, and polyphagia. When fat is used as an immediate energy source, chemicals called ketones and fatty acids are formed as waste products and are difficult for the body to excrete. Large quantities of ketone bodies in the bloodstream cause a decrease in the blood's pH and result in metabolic acidosis. The ketones are responsible for the sweet, fruity breath odor associated with DKA. If the patient is not given proper fluid rehydration and insulin to reverse fat metabolism and restore the use of glucose as a source of energy, ketoacidosis will progress to unresponsiveness, diabetic coma, and eventually death. Patients in DKA are seldom deeply comatose. Signs and symptoms of hypoglycemia versus hyperglycemia. A comparison of hypoglycemia and hyperglycemia is shown in Table 21.2 of your book. The signs and symptoms of simple hyperglycemia are usually mild and include blurred vision, polyuria, polydipsia, polyphagia, orthostatic syncope, frequent infections, and skin ulcers. What is orthostatic syncope?
Like when they stand up real quick or
Like the blood pressure changes when standing and sitting.
Okay, and then syncope part is what happens.
They pass out.
They pass out. So orthostatic syncope is when they have a change in their position, such as going from laying to sitting or sitting to standing, and they have a syncopal episode. They pass out. All right, the resulting signs and symptoms manifest these etiologic factors: polyuria, polydipsia, polyphagia, nausea and vomiting, tachycardia, Kussmaul respirations. What are Kussmaul respirations?
Rapid respirations.
Yes. Warm, dry skin, dry mucous membranes, a fruity odor of ketones on the breath, abdominal pain, and sometimes fever. The respiratory rate is usually elevated and the tidal volume is increased because of ketonemia, acidosis, and to relieve excessive burden of CO2 by the body. These respiratory changes result in hypocapnia. DKA results in both Kussmaul respirations and metabolic acidosis. In patients with type 2 diabetes, DKA is rare because insulin is still present. With increased duration of type 2 diabetes, a loss of pancreatic insulin production may occur. This table shows a comparison between hypoglycemia and hyperglycemia. Again, that's table 21.2 in your book. Know the difference between those. Hyperosmolar hyperglycemic syndrome, or HHS, is also called hyperosmolar non-ketotic coma, or HONK, H-O-N-K. That makes me giggle a little bit. A metabolic derangement that occurs principally in patients with type 2 diabetes. This is characterized by hyperglycemia, hyperosmolarity, and an absence of substantial ketosis. The term hyperosmolarity describes high concentrated blood as the result of relative dehydration. Key signs and symptoms of HHS include hyperglycemia, altered mental status, drowsiness, lethargy, severe dehydration, thirst, and dark urine, visual or sensory deficits, partial paralysis or muscle weakness, and seizures. The clinical features of HHS, or HONK, and DKA tend to overlap and are often observed simultaneously. HHS or HONC often develops in patients with diabetes who have a secondary illness that results in reduced fluid intake. Patients with HHS or HONC do not experience ketoacidosis. Table 21.3 compares hyperglycemic conditions. Patient assessment of endocrine emergencies, similar assessment as with any other medical patient. Patients with diabetes may have silent or painless heart attacks. It is imperative to maintain a high index of suspicion and treat patients aggressively. For your scene size up, evaluate the scene safety, ensure all hazards are addressed, insulin syringes on the bedstand, insulin bottles in the refrigerator, a plate of food, a glass of orange juice, all those are important clues that may help decide the problem. Ensure the personal protective equipment is readily available. Question bystanders on events leading up to your arrival. Determine whether this is your only patient and whether trauma was involved, and decide whether you will need any additional resources. For your primary survey, form a general impression. Perform a rapid scan. How does this patient look? Are they anxious, restless, or listless? Are they apathetic or irritable? Are they interacting appropriately with the environment? In patients with altered mental status, suspect a low blood glucose level. Identify life threats and provide life-saving interventions, particularly airway management. Determine the level of consciousness using the AVPU scale. If unresponsive, the patient may have undiagnosed diabetes. Perform a cervical spine immobilization when indicated and provide rapid transport. Assess the patient's airway and breathing. Patients showing signs of inadequate breathing and altered mental status or an O2 sat of 94% or less should receive high-flow oxygen at 12 to 15 liters per minute via a non-rebreathing mask. A patient who is hyperglycemic may have rapid, deep respirations, Kussmaul respirations, and a sweet, fruity breath odor. A patient who is hypoglycemic will have normal or shallow to rapid respirations. If the patient is not breathing or is having difficulty breathing, open the airway and insert an airway adjunct and assist ventilations. Continue to monitor the airway as you provide care. If the patient is unresponsive, treat him or her as any other unresponsive patient with attention to the airway. If dextrose is indicated, use of an advanced airway should be avoided until dextrose has been administered. Why would you think that's the case?
Because when you give them dextrose, they're more likely going to wake up.
Right, and then what's going to happen?
They're going to start trying to pull it out.
Okay.
They're going to throw up.
You're gonna have a whole lot of problems you weren't prepared for. Carefully monitor.
PRT.
Do what?
I said, and then after all that, they want a PRT.
Exactly. Yeah, usually if they have a long-standing history of this, they do not want to go to the hospital. Carefully monitor the airway in patients with hypoglycemia, hyperglycemic crisis, or other complications such as stroke or seizure. A patient with dry, warm skin indicates hyperglycemia. A patient with moist, pale skin indicates hypoglycemia. And a patient in hypoglycemic crisis will have a rapid, weak pulse. History taking. Investigate the chief complaint. Responsive patients usually are able to provide their own medical history. If the patient has eaten but has not taken insulin, hyperglycemia is more likely. If the patient has taken insulin but not eaten, I got tongue-tied on that one. Let me start again. If the patient has eaten but has not taken insulin, hyperglycemia is more likely. If the patient has taken insulin but not eaten, hypoglycemia is more likely. If the patient is not thinking or speaking clearly or is unresponsive, attempt to obtain a medical history from family members or bystanders. Physical signs may guide you in determining whether the patient is hypoglycemic or hyperglycemic. Obtain a sample history. What is sample? Anybody know what sample stands for?
Signs and symptoms, allergies, medication, last oral intake, and events leading up to.
What's the P?
Provocation?
Nope. What does the P stand for?
Past pertinent medical history.
That's good.
Very good. Y'all, we're halfway through this class, and if you can't tell me what sample stands for, we are in trouble. Signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading up to this incident. Okay? Ask the following questions of any ill patient who has a history of diabetes. Do you take insulin or pills to lower blood glucose? Have you taken your usual dose of insulin today? Have you eaten normally today? Have you had any illness, unusual amount of activity, or stress today? Also ask the patient or family about the following: the patient's last meal and insulin dose, any vision changes, headaches, dizziness, or bleeding, a recent change in the patient's bowel movements or eating habits, tingling, numbness, or swelling of the extremities. When assessing a patient who might have diabetes, check to see whether he or she has an emergency medical identification device. For your secondary assessment, assess unresponsive patients with a full body exam looking for clues to their condition. With unresponsive patients or patients with an altered mental status, look for problems or injuries that are not obvious. The patient may have sustained trauma resulting from dizziness or from changes in level of consciousness. An altered mental status may also be caused by something else. Systemic examination will help. When you suspect a diabetes-related problem, a secondary assessment should focus on the patient's mental status and ability to swallow and protect the airway. Obtain a Glasgow Coma Scale score to track the patient's neurologic status. Vital signs: obtain a complete set of vital signs. Identify abnormal vital signs when you know the blood glucose level is too high or too low. Remember, the patient may have abnormal vital signs and a normal blood glucose value. Monitoring devices: glucometers measure the glucose level in whole blood using either capillary or venous samples. It's important to read and understand the operator's manual before use. The normal range for glucose levels in blood in non-fasting adults and children is 70 to 120 milligrams per deciliter. The blood glucose level in neonates should be higher than 70 milligrams per deciliter. Reassessment: it's important to reassess the diabetic patient frequently to assess changes. Monitor the airway carefully and be alert for potential vomiting, especially if glucose has been administered orally. When patients who are hypoglycemic are given large quantities of glucose orally, they tend to become nauseated. Document each assessment, your findings, the time of the interventions, and any changes in the patient's condition. Base your administration of glucose on serial readings and keep the hospital personnel informed. Emergency medical care of endocrine emergencies, general management. Place the patient in a position of comfort. If the patient has altered mental status, establish an IV line with 0.9% normal saline or a saline lock. Measure the blood glucose level immediately and initiate treatment if the reading is less than 60. Glucagon is administered 1 milligram intramuscularly or IM with a greatly increased recovery time. The decreased osmolarity in these concentrations is less caustic to the veins and tissues. If the patient's condition does not improve after a dose of dextrose, and if you suspect a narcotic overdose, consider administering naloxone. Transport the unresponsive patient supine or in the lateral recumbent or recovery position. If there are indications of increasing intracranial pressure, transport with the head elevated to a 30 to 45 degree angle and the head midline. Always keep the mouth and pharynx sectioned, free of secretions, vomitus, and blood. Management of hypoglycemia. It includes immediately increasing blood glucose levels. If the hypoglycemic patient is alert and able to swallow without the risk of aspiration, administer sugar by mouth. Do not be afraid to give too much sugar. Do not give sugar-free drinks that are sweetened with saccharin or other synthetic sweetening compounds. Oral glucose may also be given. The first-line medical treatment for patients with hypoglycemia is to administer oral glucose. If not possible, administer dextrose via the IV route. Administering oral glucose. This is a commercially available tablet or gel form. The only contraindications are the inability to swallow or the patient being unresponsive. Aspiration can occur. If your hypoglycemic patient is unresponsive, or if there's any risk of aspiration, do not give anything by mouth. Never give anything by mouth to an unresponsive patient, even if you suspect hypoglycemic crisis. Instead, administer IV or IO glucose or IM glucagon. Reassess the patient frequently after administering glucose. Remain alert for airway problems, sudden loss of consciousness, or seizures. Do not delay transport just to give additional oral glucose if the patient has an altered mental status. The risk of increasing the glucose level of a patient who is already hyperglycemic is minimal. The patient with diabetes who is unresponsive and having seizures is more likely to be in a hypoglycemic crisis. For patients presenting with signs of dehydration, administer a 20 milliliter per kilogram bolus of an isotonic crystalloid solution. Reassess the patient after the initial bolus and repeat if needed. Administering IV dextrose. Administer IV dextrose if hypoglycemic patient has an altered mental status or is unable to swallow. Contraindications include the presence of increased intracranial pressure or possible intracranial bleeding. Administering glucose in the presence of hypokalemia worsens the effects of low potassium. Doses of dextrose are as follows: 12.5 to 25 grams of D50 in adults, 0.5 to 1 gram per kilogram dose via slow IV push of D25 for children aged 1 and older, 200 to 500 milligrams per kilogram of D10 solution via slow IV push for neonates and infants. Give dextrose by IV push while carefully monitoring for infiltration into local tissue. What does that mean?
The IV didn't blow.
Right, so if the IV blows and this solution is going into the tissue around the IV site.
Causes it to be necrotic.
Absolutely, it does. It kills that tissue.
I seen a nurse do that the other day.
That's terrible.
Right. He was trying to push it in the IO and didn't even have an IO in, so he pushed it in the leg.
Wow. The steps for administering dextrose to a patient with an altered level of consciousness are summarized here. Insert an IV line with the largest catheter and in the largest vein. Attach an IV bag of an isotonic crystalloid solution, such as 0.9% normal saline. Check the IV line carefully to confirm that it is patent and flowing freely. Inject a test bolus of 10 to 20 milliliters of normal saline. Open the IV line wide, crimp the line superior to the administration port, and administer 12.5 to 25 grams, which will be 25 to 50 milliliters of dextrose slowly. Depress the plunger slowly to avoid rupturing the vein. When administering D50, draw back on the syringe to observe a blood return. Recheck after 1/2 of the dose has been given by pulling back on the plunger again to check for blood return, and flush the IV line by opening the line for a few seconds. Y'all, this stuff is really thick. If you've not ever prepped it for your partner, if you've not ever played with it, dextrose is very thick. It's nothing but sugar water. So you want to make sure that you have a large catheter to support that thick solution. You want to make sure you have a large vein so that you're not putting too much pressure on the vein as you inject the solution. And you want to push it slowly so that if you do blow the vein, you're not going to have a massive amount of this solution that goes into the tissue because, like Jessica said, this is necrotic. It causes cell death. So as much as you can minimize that, the better off the patient's going to be. Administering glucagon. Glucagon IM is an option when IV access cannot be obtained in hypoglycemic patients. Glucagon is only effective when there are stores of glucogen to draw from. It is supplied in 1 milligram ampules. So if the solution you give IV is necrotic and can harm the patient, why do we prefer it over an IM injection of glucagon?
Because it works faster.
Absolutely. So when you give this IM injection, you have to allow time for that muscle to absorb that medication and for it to send it through to the bloodstream. When you give an IV medication, you're going directly to the bloodstream, so it works almost instantly. All right, the dosage of glucagon is 0.5 milligrams for children who weigh less than 20 kilograms. The dosage is the same as adults for children who weigh more than kilograms. Glucagon should be used in conjunction with dextrose whenever possible. Management of hyperglycemia and DKA. If the patient's glucose level is more than 250 milligrams per deciliter, the physician will probably order treatment for DKA. The goals of pre-hospital treatment of DKA are to begin rehydration and to correct the patient's electrolyte and acid-base abnormalities. Maintain the airway and administer oxygen. Be alert for vomiting and have suction ready. Consider paramedic backup for definitive airway control if needed. Gain IV access and administer a 20 milliliter per kilogram bolus of an isotonic crystalloid solution for signs of dehydration. Treat the patient symptomatically, providing oxygen and IV fluids as needed. Management of HHS or HONC. I smile a little every time I say that. Y'all can't see me do it, but I do. Every time I say honk, I smile just a little. Management follows the pathway for dehydration and altered mental status. Advanced airway management may be indicated and should be completed as early as possible. Cervical spine immobilization should be considered for all unresponsive patients. Obtain a blood glucose level as soon as possible. Large bore IV access, that would be an 18 gauge, should be gained as soon as possible. In patients with a history of heart failure and or renal insufficiency, give fluid sparingly. Fluid deficits in patients with HHS or HONC may amount to 10 liters or more. Hematologic emergencies. Hematology is the study of blood. It also addresses the ways in which the constituent parts of blood are involved in health and disease. The blood components include red blood cells, white blood cells, platelets, individual proteins involved in the bleeding and clotting cascades, hematopoietic system. Hematologic disorders refer to any disorder of the blood. Hemolytic disorders refer to disease processes that cause the breakdown of red blood cells. Hemostatic disorders refer to bleeding and clotting abnormalities. As an advanced EMT, you should have a basic understanding of the hematopoietic system and hematologic disorders and how to respond. A&P review for hematology, blood and plasma. Without blood, we would not be able to live. The functions of blood: respiratory, transports oxygen from the lungs to the tissues and carbon dioxide from the tissues to the lungs. Nutritional, carries nutrients from the digestive tract to cells throughout the body. Excretory ferries the waste products of metabolism from the cells where they are produced to the excretory organs. Regulatory transports hormones from their target organs and transmits excess internal heat to the surface of the body to be dissipated. Defensive carries defensive cells and antibodies which protect the body against foreign organisms. Your components are plasma, that is the straw-colored fluid that is 92% water and 6 to 7% proteins. The remainder consists of a variety of other elements, including electrolytes, clotting factors, and glucose. Plasma accounts for 55% of the total blood volume. All of the formed elements are transported through the body in plasma. The cells are red blood cells, or RBCs. 99% of the formed elements in blood are red blood cells. These are also called erythrocytes. Within the red blood cells, iron-rich hemoglobin is responsible for carrying oxygen to tissues. Red blood cell production occurs within stem cells. Oxygen attached to the hemoglobin gives blood its characteristic red color, although many other factors can change the color of blood, such as carbon monoxide poisoning. White blood cells, the WBCs, they are also called leukocytes. They provide the body with immunity against foreign invaders, fighting infection, and removing dead cells. White blood cells are derived from stem cells. There are several types of white blood cells, each of which performs a specific task in relation to maintaining the immune system. Platelets are your thrombocytes. They are the smallest of the formed elements and are responsible for clot formation. Approximately 2/3 of the platelets circulate throughout the blood, the rest are stored in the spleen. Platelets are also derived from stem cells. When damage occurs to a blood vessel, platelets are sent to the site of injury to assist in creating a blood clot to stop the bleeding. Platelets form the initial plug following vascular injury. Conditions such as thrombocytosis can result in other dangerous medical conditions such as thrombosis. Hemostasis is a highly complex process that allows the body to stop bleeding through vascular spasm, coagulation, and platelet plugging. Any process that interferes with the activation or continuation of the clotting cascade or hemostasis is known as coagulopathy. That's a fun word. Blood-forming organs and red blood cell production. Many parts of organs can alter or affect the hematologic system. The major players are bone marrow. This is the primary site for blood cell production. It is found in most long bones, the pelvis, the skull, and vertebrae. The liver produces clotting factors found in blood. It filters the blood, removing toxins. It is essential to metabolism and homeostasis. It is highly vascular and stores blood in itself. The spleen is also very vascular. It filters and breaks down red blood cells, helps produce white blood cells, and it is important in providing homeostasis and infection control. Blood classifications. These were developed to ensure compatibility and prevent medical problems during blood component replacement. In the ABO system, the red blood cell classification types are O, A, B, and AB. They indicate which antigens are found in the plasma membrane. See Table 21.4 in your book. Blood contains a secondary antigen known as the Rh antigen. In the United States, 85% to 90% of all whites and African Americans have this antigen. Transfusion reactions. Some patients may have previously received a blood transfusion. It is important to determine a patient's blood type and the type of blood received. When a patient receives blood or plasma that matches his or her classification, A positive into A positive, or the universal donor blood type, which is O, problems rarely arise. If a patient receives a blood type that is different than his or her own, a transfusion reaction will occur. Transfusion reactions may also occur when a patient with A blood receives an A positive transfusion, but they are rare. Blood reactions are similar to an anaphylactic reaction. They occur rapidly and can cause severe circulatory collapse and even death. When a patient receives a blood transfusion, it is important to monitor the patient very closely for the first 30 to 60 minutes. This is the time frame in which transfusion reactions usually begin. Pathophysiology of hematologic emergencies. Sickle cell disease is the most common inherited blood disorder. It can occur in anyone but primarily affects African American, Puerto Rican, and European populations. Mortality at younger rates is common. Average life expectancy is 42 years for men with sickle cell anemia and 48 years for women with this disorder. Sickle cell disease starts with a genetic defect of the adult type hemoglobin HbA, which is hemoglobin A. When the red blood cells are first developing their membranes, they may become rigid and deformed. Defective red blood cells have an oblong shape instead of a smooth round shape. This shape makes the red blood cell a poor oxygen carrier, which means a patient with this disease is highly susceptible to hypoxia. Since sickle cells also have a much shorter lifespan than normal erythrocytes, the patient is also more prone to develop anemia. The odd shape may also cause red blood cells to lodge in small blood vessels, resulting in thrombosis. Defective red blood cells may migrate to the spleen, causing the organs to swell and rupture, which can result in death. Sickle cell disease may result in aplastic crisis, a hemolytic crisis, or thrombosis. In both cases, the patient may have rapidly evolving anemia, leukocytosis, and fever. A sickle cell crisis may manifest in several ways. Vaso-occlusive crisis, which results from blood flow to an organ becoming restricted, causing pain, ischemia, and often organ damage. This usually lasts between 5 and 7 days. Frequently, circulation to the spleen becomes obstructed as a result of narrow vessels and function of removing damaged red blood cells. Acute chest syndrome, a vaso-occlusive crisis that can be associated with pneumonia. Common signs and symptoms include chest pain, fever, and cough. Vaso-occlusion in the brain may result in a CVA. Aplastic crisis is worsening of the patient's baseline anemia. It causes tachycardia, pallor, and fatigue. This may be caused by the parvovirus B19, which affects the production of red blood cells. Hemolytic crisis is an acute accelerated drop in the patient's hemoglobin level. It is caused by red blood cells breaking down at a faster than normal rate. It is common in patients with glucose 6-phosphate dehydrogenase deficiency. Splenic sequestration syndrome. This is caused by painful acute enlargement of the spleen. It causes the abdomen to become very hard and bloated. That was a mouthful. These figures show normal. Right, I don't want to. These figures show normal red blood cells versus sickle cells. So the sickle cell gets its name from that sickle shape. Y'all all know what a sickle is?
No.
No. I know you've all seen a picture of the Grim Reaper. The Grim Reaper, its little axe thing that it carries, its blade is curved. That's called a sickle. Y'all know what I'm talking about?
Yeah. It looks like a half moon.
Yes, that is called a sickle. And that's why this is called sickle cell, because the cells are shaped like sickles. Little fun fact, might be a good bonus. All right, in acute crisis, patients may have substantial pain resulting from congested vessels that do not allow for the passage of oxygen and nutrients into tissues and joints. They may experience frequent infections, which can lead to sepsis and death. Over time, various organs may be destroyed as circulation is impeded. Patients may have signs of mild dehydration, splenomegaly, cardiomegaly, and many other complications. Patients with chronic sickle cell attacks are vulnerable to severe life-threatening complications. Y'all, this is very painful. It is a very, very painful disorder. And these patients normally know when they're in crisis. They can tell you. And we do have some that are in Gadsden. And it's
Yeah, there's one we run several times.
yeah, he'll go sometimes 2 and 3 times a week to the hospital if he ever hits crisis. But he will tell you he's in crisis, and it'll just about break your heart because these are grown men in tears, like they're hurting so bad. Complications can take days to weeks to develop, and some of the potential complications of sickle cell disease are as follows: cerebral vascular attack, gallstones, jaundice, osteonecrosis, splenic infections, osteomyelitis, opiate tolerance, leg ulcers, retinopathy, chronic pain, pulmonary hypertension, and chronic renal failure. Anemia is defined as a hemoglobin or red blood cell level that is lower than normal. It is associated with some types of underlying disease processes. Iron deficiency anemia is the most common type. In children, it is most often related to premature birth or low birth weight. Anemia may sometimes be caused by an inherited hemolytic disorder. In these disorders, when the red blood cells are first developing their membranes, they become rigid and deformed. Anemia may also be caused by hematologic disorders resulting from a deficiency of an enzyme known as glucose 6-phosphate dehydrogenase. The most common type of acquired anemia develops when the flow of red blood cells is disrupted owing to problems with blood vessel linings or blood clots. In autoimmune disorders, red blood cells are destroyed by the body's own antibodies. Anemia can also have serious consequences for people who travel to high altitude areas. Patients with anemia will report feeling worn down, having no energy, or feeling as if they have overexerted themselves. Owing to the reduction in their hemoglobin levels, some may have angina-type chest pain related to decreased oxygen availability to the heart muscle. Other conditions that are common in patients with anemia include leukopenia and thrombocytopenia. Clotting disorders, these are abnormalities in clotting of the blood. Thrombosis is the development of a blood clot occurring in arterial or venous blood vessels. Patient's symptoms are related to the part of the vascular system in which the clot occurs. Thrombophilia is the tendency to develop blood clots. It affects a large number of people around the world. It is a common medical problem. Thrombosis may manifest as a formation of a clot in the blood vessel or in one of the chambers of the hearts. A pulmonary emboli secondary to deep vein thrombosis are leading causes of death in hospitalized patients. Many patients with thrombophilia receive anticoagulant medications that thin the blood. Risk factors include recent surgery, impaired mobility, congestive heart failure, cancer, respiratory failure, infectious disease, age older than 40 years, being overweight or obesity, smoking, or oral contraceptive use. Hemophilia is a genetic bleeding disorder in which clotting does not occur or occurs insufficiently, and this is the von Willebrand disease. The body is unable to develop spontaneous clots as normal. It results in increased bleeding time, occurs predominantly in males, classified into 2 primary types: hemophilia A, which is the most common type. It has low levels of factor VIII. Hemophilia B is the second most common type. It has a deficiency of factor IX. The levels of factors VIII and IX determine the severity. Signs and symptoms of hemophilia A and B are the same. You have acute and chronic bleeding, which can occur at any time and may or may not be life-threatening. Illness or injuries or illness that cause bleeding in hemophilia patients should be taken seriously. Spontaneous intracranial bleeding is common, and this is frequently a cause of death. Patients with substantial acute bleeding episodes require hospitalization for transfusions. In addition to managing the ABCs, be alert for signs of acute blood loss. Note any bleeding of unknown origin. Patients may exhibit signs of hypoxia owing to the reduction in oxygen carrying capacity. Disseminated intravascular coagulation, also known as DIC. This may result from any number of life-threatening conditions. It progresses in two stages. First, free thrombin and fibrin deposits in the blood increase, and platelets begin to aggregate. Second, uncontrolled hemorrhage results from the severe reduction in clotting factors. The mortality rate for patients with DIC is quite high. Identify signs and symptoms commonly associated with DIC or progression towards this coagulopathy. Patient assessment, you're going to do your scene size up, ensure the scene is safe for entry, consider the mechanism of injury or nature of illness, determine the number of patients, assess for hazards and the need for additional help. Standard precautions should consist of gloves and eye protection at a minimum. Evaluate each situation quickly and make sure the necessary personal protective equipment is readily available. Patients experiencing a vaso-occlusive crisis are often in extreme pain and would benefit from administration of analgesics. Your primary survey, an African American patient or any patient with Mediterranean descent who reports severe pain may have undiagnosed sickle cell disease. Remember that even though a person has a history of sickle cell disease may not be causing the current problem. Always perform a thorough, careful primary survey, paying attention to the ABCs and immediately correcting any life-threatening issues. Perform a rapid full body scan of the patient to form an initial general impression of the patient. Assess the patient's airway and breathing. Patients showing signs of inadequate breathing, an altered mental status, or an SpO2 of 94% or less should receive high-flow oxygen. Be aware that even minor trauma during these procedures can result in bleeding in the airway and increase the risk of airway compromise. Continue to monitor the airway as you provide care. Check the patient's circulatory status. An increased heart rate represents a compensatory mechanism. In patients with suspected hemophilia, be alert for signs of acute blood loss. Note any bleeding of unknown origin. Patients with hemophilia may exhibit signs of hypoxia or shock. Fluid resuscitation may be necessary for these patients. Rapid transportation will depend on the severity of the patient's condition and the patient's wishes. Transport to an emergency department should be recommended to any patient who is experiencing a sickle cell crisis or has a history of hemophilia and is bleeding. History taking, investigate the chief complaint, be inquisitive about the patient's history and sample history. What does sample stand for? Not Haven.
Symptoms, allergies, medications, past medical history, last oral intake, and events leading up to.
Okay, thank you. Do not take a call for a person having a sickle cell crisis lightly. Physical signs such as swelling of the fingers and toes, priapism, which is what?
An erection.
Yes. And jaundice may guide you in determining whether the patient is experiencing a sickle cell crisis. If the patient reports pain, ascertain whether the patient is isolated to a single location or whether it is felt throughout their entire body. Look for changes in the level of consciousness and symptoms. In a patient with known sickle cell disease, ask the following questions in addition to obtaining a sample history. Have you had a crisis before? When was the last time you had a crisis? How did your last crisis resolve? Have you had any illness, unusual amount of activity, or stress lately? Secondary assessment may be performed on scene, en route to the emergency department, or not at all. Systematically examine the patient, focus on major joints at which cells congregate, and obtain your patient's baseline vitals. Evaluate and document mental status using the IFPO scale. Table 21.5 in your book shows common findings in the patient with blood disorders. Obtain a complete set of vital signs. Use pulse oximetry if available, and keep in mind that the oxygen saturation reading you obtain may be inaccurate as a result of the patient's anemic state. Reassessment. It is important to reassess the patient frequently to determine if there have been changes in his or her condition. Document each assessment, your findings, the time of the interventions, and any changes in the patient's condition. Communication with hospital staff is important for continuity of care. Your run report is the only legal document that shows appropriate care was provided. Follow local protocols for patients who refuse treatment or transport. Emergency medical care of hematologic emergencies. Emergency medical care for any patient with problems related to a blood disorder should include oxygen. The amount needed and how it is given depends on the severity of the patient's condition and respiratory status. Fluids. Initiate an IV fluid replacement as indicated for the specific disorder or chief complaint. Transport to the closest facility and most appropriate facility. Pharmacology. Pain management is necessary. Remember that patients may have lived with a disease for a long time and thus may have a high pain threshold. Follow local protocols for pain management. Comfort and rest. Place the patient in a position of comfort and cover the patient to maintain his or her body temperature. Psychological support. Be supportive and communicate with the patient. Management of specific conditions. Perform a thorough assessment and contact the hospital to help sort out the signs and symptoms. Care for sickle cell disease might include analgesics for pain, antibiotics to prevent infection, and blood transfusion as required. In cases of anemia, check and monitor the airway and the patient's breathing. Ensure that the red blood cells that are present are being maximized while administering oxygen. Do not be surprised if you have to control substantial nosebleeds in any patient with anemia. For patients reporting chest pain, call early for paramedic backup. Although patients with hemophilia may require IV therapy in cases of unstable hypotension, understand that the patient actually needs a transfusion or plasma. It is crucial to identify DIC and establish treatment early. Maintain the patient's airway, administer supplemental oxygen, and treat the patient for shock. Be optimistic but honest with patients and family. Okay, y'all, that is it for chapter 21. We have any questions about this? Nope. All right.
I don't.
No question. No question.